Good morning, seniors. I hope you guys are having a good day today. You're over in San Antonio. It's a rainy Friday morning. Sorry that just went ding. It's funny because now that I know you guys are hearing that, um, I'm a little bit more cognizant. The unfortunate thing is I can't turn it off because otherwise it mutes me as well. So we will get started. Chapter 15 is GI disorders for your peds. I kind of like this because I know I got to help teach your GI for adult health. We're going to talk about the components of the abdominal examination, important questions to ask when you're doing a history about GI problems. We're going to talk about GI diseases. We'll look at them in functional versus surgical versus infectious. And we're going to describe GI diseases that present with abdominal pain, GI disorders with regurg and vomiting, GI disorders associated with constipation, and GI problems manifested by abdominal wall defects. Lots and lots of GI issues on little ones, especially babies. So to hop into this, if you remember when we talked about our adult patient, the GI system really is everything from the mouth to the rectum. It's going to be every bit of your structures for mastification, where it's breaking down the foods, digestion, elimination. So just like on the adult, you've got your mouth, you've got your esophagus that leads down to the stomach. The stomach, of course, then goes into the small intestine, the large intestine, the rectum. But then we also, look at the liver, the gallbladder, the bile ducts that feed into that, because remember, your bile ducts is what's important to be able to help break down that food. Your pancreas. So it's not as much fun for me to teach this on here because I always like to ask you guys questions. Like when you're doing the history, what kind of questions are you going to ask them? But, it's really important that you ask, have they had any GI problems or diagnoses since they were born? How long has this been going on? Do they have associated constipation or diarrhea? How's their appetite? Is their appetite any differently? Have they been running a fever? Do they have cramping with it? Do they have specific abdominal pain with it? And when I say cramping versus abdominal pain, is it diffuse abdominal tenderness, or is it one specific area like the gallbladder or appendix? Because especially with the rate of obesity increasing, we are seeing a lot more gallbladder disease in kiddos. And then, one of my good friends is a researcher, and appendixes are getting younger and younger with kiddos with appendicitis. And he really thinks it's because of all of the processed foods. So just remember, we have lots and lots of different issues that are, as our diets change, as our patient clientele changes, there are lots of things out there. On their assessment, you're going to go back to your old carts. How long have they been sick? What is the associated symptoms? Are there any contributing factors? What makes it worse? What makes it better? Have they been exposed to anyone that has been sick? So just lots and lots of things to look at to make sure you're doing an adequate diagnosis or adequate assessment on them. When you get to the actual assessment itself, remember, you do need to check their mouth. Do they have some dental caries? Think of your infants that a lot of times get colicky abdominal symptoms with diarrhea when they're teething. Maybe it's a kiddo that's 2 or 3 and has bottle mouth, and that's where that's the layman's term, but where parents put them to bed with a bottle every night, so they've got rotten teeth or a lot of dental caries. Well, that is definitely going to affect the GI, function of these kiddos. Besides, it has a chronic source of infection with these kids. So make sure you're really looking at that mouth, looking at that tongue, looking at that throat. Do you see any lesions there? Do they have any anterior cervical lymphadenopathy of, of the neck here? When you're looking at the belly, remember you're going to inspect the belly first. You're going to look, is it concave? Is there any obvious masses or lesions? And then after you inspect it, the next thing you're going to do is you're going to auscultate. Because remember, you want to auscultate before you do any kind of palpation or percussion, because that can change the sounds of the bowel sounds. So when you listen to those bowel sounds, you do need to make sure you're going to listen to all 4 quadrants when you auscultate. And you're going to make sure, are those bowel sounds normal active, or are they hyperactive, or they're hypoactive? And just a little key here, I don't remember if this is in your book, because I actually wrote this or put together this PowerPoint probably about a week ago. But just because a bowel sounds are hypoactive doesn't mean they can't have diarrhea. And the reason why I say that is because, if they have really bad diarrhea, they may eat something and the bowel sounds may be hyperactive, and then it may just shoot everything through their system, and then it goes to hypoactive. So if they haven't just eaten, it could be hypoactive. So just be aware of that. Normally, you think of the hypoactive bowel sounds and just constipation, but be aware that it can, you can have some weird stuff going on. Absent bowel sounds are always a concern. You want to make sure you listen for a full 60 seconds before you say they're absent, because it is a big deal. Do they have an obstruction in there? And then after you auscultate, you're going to do your percussion. Is there tympany or dullness in places? Do you see, does it sound like it's a balloon where there's fluid, or ascites? And then after you do your percussion, you're going to do your palpation. And remember, you're going to do your palpation lightly all over to see if there's any tenderness. Then you're going to do your rebound tenderness. Remember, it's your hand straight down and up to check for peritoneal irritation, as well as, think about your appendix. You want to notice, if they do have any kind of tenderness when you're palpating, whether it's with the light or the deep, is it referred? When you press in the left lower quadrant, is it hurting in the left upper quadrant? Do they have a fluid wave when you palpate? Is it the rebound tenderness where when you let down, it doesn't hurt as bad? It may hurt a little bit, but it hurts worse when you let up. So all of those things to really look at when you're doing a good evaluation. All right, cleft lip and palate. We've kind of talked about some of those fistulas and other problems as an adult, so it's kind of fun to talk about these as kids. We don't see the cleft lip and palate being such a big deal for adults because most of them have been repaired by the time they've got to be an adult. But just remember, your cleft lip is that opening, and it can be from the lip here all the way up to the nose, and it can be, just a little bit of a slit. You can look in a mouth, and in the palate on the top, you can see just a little slit, or it can be very, very big. A different chapter 7, really goes into quite a bit more depth about that, so definitely read up on that. What I've got pictures here is the tracheoesophageal fistulas, and that's where you have that abnormal connection, which is the fistula between the esophagus and the trachea. And most of the time that esophagus is discontinuous and definitely will cause, immediate feeding difficulties. Look at, in that first picture there, you've got your normal esophagus and stomach. In the next one, you've got that atresia with the distal fistula. See how it's at the bottom? Then you've got atresia with double fistula. Then on the left bottom, you've got that atresia with proximal fistula. My picture is in the way. Whoops. I got to figure out how to go back because there's a lot of other information for that slide. But just remember, you know, when you're looking at those, they're definitely going to have quite a bit of feeding difficulties. One of the big things you want to look at is if baby's having problems handling their secretions. That kind of lets you know that there is, you know, a problem somewhere, whether it's mouth, whether it's esophagus, whether it's abdomen, but definitely needs to be rechecked. Is the baby getting cyanotic when you're feeding them? You know, that can be a lot of different things. That can be the fistula, that can be the heart, it can be the lungs. So just know, you know, they need further evaluation. Maybe you go to put a feeding tube in baby and you have some resistance. So just know, you know, you want to definitely take your time and do a good thorough evaluation of those kids with the potential fistula or any child with any kind of feeding difficulty. Some of, you know, we always have test questions on emergency care for those kids. Remember, you're always going to do your ABC, airway, breathing, circulation, but remember, you want to prevent your aspiration. So you want that head of the bed elevated to 30 to 45 degrees. There's going to be a tube that's placed in the proximal pouch to make sure that they're getting feedings, but you are going to want to make sure they have that IV access. They may need some oxygen. They're probably going to be in the hospital, and most of these kids are going to be surgically repaired. They are going to need IV support after the surgery, and of course antibiotics because they're high risk for infection. If you think about different foods, even TPN going through that, I mean, there's just a lot of things that can get infected in there. You may have to do some frequent suctioning. And then all of these kids are going to have a acid suppression therapy, most of them with a PPI. And again, that's because any kind of surgery, you are not going to want anything to inflame it. And think about your gastric secretions, and your acid is going to inflame things. And then after they have the surgery, they will be checked for leak about 5 to 7 days out, because you have to remember that suture line has to heal. And if there's no leak at 5 to 7 days out, then they can start oral feedings. For the teaching of mom and dad, you know, or caregiver, you're going to want to explain the need for the surgery. You're going to want to explain the need for the IV fluids. You want to definitely provide emotional support. Think about how most parents are so excited to have this baby, and then they've got some real problems, and maybe they weren't financially ready for baby with chronic problems like this. You know, is their insurance good? Is this going to put strain on them for having to take out of work? So lots of different things that could be there. You know, one of the other things that you can do to help baby is after surgery, before they start the feedings, give them a binky or pacifier. And they call that non-nutritional suckling. And that's just so that baby gets all of those muscles working like they should as they're sucking on that pacifier. You're going to teach caregivers how to monitor for signs and symptoms of GI reflux, because that's really important, even after they start those oral feedings, because again, you don't want anything to inflame that area. You don't want them to have this surgery, do great, and then have some GI reflux and end up getting an ulcer or fistula or anything at all that could be there. And then, of course, the big thing is you're going to want to teach a caregiver to watch for pulmonary complications, because, again, think of your tracheobronchial tree that's right there that it could go down in. All right, now this slide. GI problems manifested by abdominal pain. So we have our traditional, or I shouldn't say traditional, but we hear a lot about celiac disease. As our diets are getting worse in America, we are seeing more and more celiac disease. So we're getting more education, and it's more in the media, which I think is really good. If you remember, celiac is a immune-mediated systemic disease. It's caused by the ingestion of wheat, and in individuals that really can't break that down. So basically, when they eat gluten, a protein that's found in the wheat, rye, and barley, your body basically mounts this response, and that's why it is considered a immune disease. And so basically the body kind of attacks itself. It attacks the small intestines, and it does damage the villi. And if you remember, those villi is up on the upper left, but they're kind of like those finger-like projections that kind of, it lines that. It helps with the nutrient absorption. It helps with the digestion. It helps with moving that food along. So you got to remember, if it's damaging those, that's where a lot of your symptoms are going to come from. They're not able to absorb things. They're not able to move things properly. So you just have a lot of problems with that. Signs and symptoms. You're going to see some diarrhea, vomiting, weight loss. And a lot of these patients are very skinny, but sometimes they do, you'll see it very commonly, they'll have a normal weight in the face, but they'll have very thin extremities. They have a lot of gas or flatulence from the bloating, and again, that's because they're having altered absorption in there. They're going to have foul-smelling fluids, or excuse me, stools, and that's because if they're not able to absorb it, it's going to come out in the stool. They're going to have delayed growth and development, delayed puberty. Think about not only your physical developmental milestones, but also your cognitive, because if you're not getting those nutrients like you're supposed to, it's going to delay all of that. They can have some dental enamel defects in their teeth. Very common to have a rash that is a blistering, very itchy skin rash on the elbows, buttocks, and knees. However, the rash is more common in adults and doesn't always occur in all cases, so just be aware of that. Comorbidities, again, due to the delayed absorption. You can see them being iron deficient. You can see them having B12 deficient, osteopenia, or osteoporosis because of the calcium malabsorption. And that is considered a critical. Can you imagine having a 2-year-old that's considered osteopenic or osteoporosis? You know, what kids do? They run and they fall. You know, we laugh about how resilient they are, but if baby or toddler now has got these brittle bones that have the decreased strength, or I can't think of the right word, but if they're having, you know, if their bones are thin, instead of having the strength to them, you know, they fall down, they're going to break a bone. So just remember, one of the other key things, you know, I said that it's becoming more and more common. And again, I think a lot of it is our diets of eating all of these super processed foods. They've got a lot of different chemicals in it to keep it fresh. But it now is rated that this occurs 1 in 141 people. So very, very wild. It does run in families. So people that have it as a family member drop from being 1 in 141 people to 1 in 22. A lot of times it comes in because of this being an autoimmune disease. Remember, anytime you have one autoimmune disease, you're more likely to have another one. So we see this in other being in conjunction with other autoimmune diseases, such as, your liver, your thyroid, diabetes, rheumatoid arthritis, lupus, Sjogren's disease. So anyway, anytime you just want to educate that caregiver, anytime you have a kiddo with one autoimmune disorder, you definitely want to be on the lookout for other autoimmune disorders. Sorry, I know my dinger's going off, and I'm waiting for some important emails, so I had to make sure that wasn't it. So our kiddos with celiac, you want to educate those caregivers to be on the lookout for other autoimmune diseases. You as a nurse want to be, maybe that child hasn't, but you in your mind know that you need to assess for those others. Diagnostically, they're going to have a CBC because, you want to check for your anemia. You want the anti-tissue transglutamase antibodies that look for celiac. You're going to look at the IgA. You're going to look at vitamin B12 levels, ferritin, TIBC. Remember, the TIBC is that total iron binding capacity. And what the TIBC is specifically when you're looking at somebody that may be anemic, the TIBC helps you know, is this a macrocytic? Is it a microcytic? Is it not normocytic? It helps you differentiate what kind of anemia it is. The folate. You're going to check their stool for cold blood. You're going to check their stool for fats because remember, they're not absorbing in these nutrients, so they're pushing those out. And then you're also going to want to check them for H. pylori antigen in their stool. They're going to have an endoscopy and tissue biopsy for definitive diagnosis. And so you, as the nurse, are going to educate caregivers on preparing for the upper endoscopy. And they may have a lower endoscopy, a colonoscopy. You're going to want to make sure that they're having adequate IV hydration or adequate INOs so that they're not getting dehydrated. A lot of times these kiddos are in the hospital. You don't want them to start the gluten-free diet before the endoscopy exam where they can have their biopsy because you want to make sure you get that definitive diagnosis. So you're also going to work with the caregivers and, if the kiddo is old enough, with the kid as well to explain the importance of the gluten-free diet and what is a gluten-free diet. I highly recommend them visiting with a nutritionist as well because nutrition is really hard and it's hard for us as nurses. We have so much on our plate, so it's really difficult for us as nurses to make sure that we're getting in all the adequate information. So do what you can, but do refer them over. You do need to educate mom and dad or caregiver to recognize the celiac crisis, and that's when they have the extreme vomiting, diarrhea, and constipation, vomiting, diarrhea, and dehydration. When this happens, it is a medical emergency. They do need to go to the ER. And most of the time, this does have to have IV rehydration, some electrolyte replacement. A lot of times they do have to have some potassium because think about it, if they're having that severe diarrhea and vomiting, their potassium, sodium, magnesium, calcium, all of those levels can be off. All right, appendicitis. This one is a lot, to me, I think, easier because we know more about it. If you think about, your appendix is that little piece right off of the colon, that little pouch. And in kiddos, a lot of times something they eat can go in there and get trapped in there, almost very similar to like a diverticulitis in an adult. Except for a diverticulitis in an adult, a diverticulosis, a diverticulum in adults are common with straining. Your appendix is always there. So you've always got that pouch, but we will see seeds get stuck in them that will cause, because the body knows it's not there, so it gets inflamed. We will see all kinds of different things that can get in there and cause an infection. Originally, as you guys know, appendicitis was, they had to have immediate surgery because they could rupture. And if they rupture, that's a bad thing because it is going to cause peritonitis. In recent years, they have been doing a lot more IV antibiotics for acute appendicitis, and it is effective. I remember when my son, this has actually been 5 or 6 years ago, had acute appendicitis, and we go to the ER, and in my mind, I'm ready to whisk him away to surgery. And the surgeon came in and he said, we need to do some IV antibiotics and see if we can resolve this without surgery. And I looked at him, I'm like, what? I don't want this to rupture. This ruptures. This is a big deal if it ruptures. He needs surgery. And they're like, no, ma'am. All of the latest research has shown that we need to do more IV antibiotics like some of the foreign countries do. The IV antibiotics, if you get rid of the infection, get rid of the inflammation, can go back to normal. Sure enough, don't get me wrong, it was heavy duty IV antibiotics and doses. They put him in the hospital for 24 hours, sent him home on PO antibiotics, and it took care of it. So just be aware, some of those treatment modalities are changing. You still need to refer anybody, especially a child that has possible appendicitis, to the ER. And remember the chronic symptoms of that. A lot of times they have pain in that right lower quadrant or around the umbilicus area. Some patients will say they've had just a little bit of steady pain for a couple of days. It's getting more nagging and worse. By testing them, of course, you can do the McBurney's point, which is where I was talking about that rebound tenderness. Let me get my hand in front of the camera there, where you go straight down, 90-degree angle. You push down. It may be tender, but when you let up is when it's very tender. The other way, and so that checks for the peritoneal irritation. The other thing you can do is have them cough. And if it hurts in their abdomen when they're coughing, that shows you that they've got that irritation. Or you can do what's called a heel tap. And that's where, when they're laying supine, this is the end of their foot, and you tap on that heel, it can cause, that jarring motion can cause some irritation. If they're standing up, you can have them bounce up and down on their heels, and that can also show you. So lots of different ways to check that. Just remember that they do need to be evaluated because it is an acute problem. To evaluate it, they are going to do a CBC, looking to see, if they have that shift towards a bacterial infection. They're probably going to have either an ultrasound or a CAT scan, more likely the CAT scan for appendicitis and the ultrasound for gallbladder. So just be aware of that. You do need to make sure you're keeping the patient in PO in case they do have surgery. Post-operatively, you need to be talking to the parents about, how to clean the site, how to monitor for signs and symptoms of infection. Diet, you need to be talking to them about that, and activity. Inguinal hernia. We see this quite a bit in little kids, when they're crying a lot. And it's more commonly on the right side of the groin, but anything that will really increase the abdominal pressure or groin pressure, you're going to see that. But if they have history of the intermittent pain with swelling in the groin, feeling a weakness or pressure in the groin, a burning, gurgling feeling in the groin, you need to check that. And if you've never got to feel an inguinal hernia, they're pretty cool. Cool because I don't have one, but they almost feel like a little balloon. not fluid filled, but just like a little balloon. They're just, when you're pushing on it, it's just bouncy. And so you can kind of feel it as you're feeling right in there. Any kiddo that's born with a hydrocele, or if they present with a hydrocele, does need to be checked for that inguinal hernia, because they do often run hand in hand. Now, these can get strangulated. So if that child has an increase in pain, if they're tachycardic, if they have vomiting, and they haven't had a stool, you definitely want to check. You want to check, is it erythematous? Is there, edema? And so really, those both, either the incarcerated or the strangulated, are medical emergencies. Remember, strangulated, that bowel is no longer, it's up in that hernia. The bowel itself is not getting blood flow, so it is going to die. Not the child, but the bowel. So it is a medical emergency. So anytime you do have a kid with a hernia, you need to be checking, is this incarcerated, is this strangulated? And for testing purposes, here's your clinical pearl. You need to make sure you know the difference between an incarcerated inguinal hernia and a strangulated inguinal hernia. If you're not worried about incarcerated or strangulated hernia, you can ask them to copper bear down, which is going to make that hernia get bigger. You can typically reduce a hernia on examination. And they can also do what's called transillumination to rule out a hydrocele versus a hernia. And what transillumination is, if you have your pin light, I'm going to use my pin here, and let's say you've got the baby scrotum right here, inguinal canal, you put that pin light up there, and you can tell by the way it shines in there if it's a hydrocele, if it's hernia. So look up those. There's some great ones on YouTube, and if I can think about it, I will even try to look some of those up and send out to you guys. So your interventions is you're going to educate the patient, if they're old enough, caregivers, that they may need surgery. If they need surgery, how are they going to take care of that afterwards? Activity, diet. You yourself, though, are going to do IV fluids. Make sure to get the informed consent. You're going to answer questions. And think about this. It's a lot easier on a kiddo that's toilet trained. If they're not toilet trained, if they're in diapers, you need to really discuss with mom and dad or caregiver how, the importance of keeping that area clean, how to clean it, because you don't want urine or feces to get up in that, area. Umbilical hernias, remember, up on the umbilicus, and we see that more with just the kiddos that are colicky and crying a lot. A lot of times those will, though, close about a year. Once in a great while they have to have surgery, but for the most part, kiddos will close it. And remember, for any of these hernias, how they fix them. They go in, they pull the intestine out of that hernia, they put the mesh there, and then close it up. And they can do these usually laparoscopically. And once that mesh is there, the area is almost always stronger than before, so you don't have to worry about getting another hernia there. However, other places they can still get a hernia. GI problems that are manifested by abdominal pain. This is continued, and this I really like this right here. It kind of shows the differences where people might get Crohn's disease versus ulcerative colitis. They are both inflammatory bowel disorders. Crohn's disease is an immune response to injured tissue, so it causes quite a bit of inflammation of the GI tract. It can be, as you can see by that little diagram there, you can see it all over. It's kind of patchy inflammation throughout the small and large intestine both. I've seen a lot of it for some reason affecting anuses. It can affect the anus, not always, but it can. And most of the time, the most common place is the small intestine. Irritable bowel syndrome, it is going to affect just the large intestine. And think about your irritable bowel, typically cramping, abdominal pain, bloating, gas, diarrhea, constipation. And IBS is something that they do need to learn how to manage lifelong. You do want to educate them on the importance of diet, get them in to see a nutritional or have a nutritional consult. That's going to help. But IBS is not going to kill them. It may make them pretty darn miserable, but it's not nearly as serious like the ulcerative colitis and Crohn's disease. IBS, irritable bowel syndrome, does not cause changes in the bowel tissue or increase the risk for colorectal cancer like ulcerative colitis and Crohn's disease. The difference is in this is that, with IBS, they can also have the constipation. They often will have quite a bit of mucus in their stools, urgency to have bowel movements. And they can also, a lot of times, will have a comorbidity of other functional pain syndromes like chronic fatigue syndrome or fibromyalgia. IBS, you're going to do get a good history. You're going to do CBC, checking for that anemia. You're going to do stool studies for open parasites, check in stools for white blood cells, checking a stool culture. They're probably going to have an endoscopy just to rule out Crohn's disease and ulcerative colitis. But most of the time, they are completely normal in IBS. So the big thing with these is you definitely want to, all of these abdominal pain disorders you want to discuss with caregivers. You want to educate on the different disorders, the importance of getting a correct diagnosis and how to get a correct diagnosis. You want to do, like I said, the nutritional consult, and you want these patients to try to have as much of a normal life as possible. If it is true ulcerative colitis or Crohn's disease, they're going to be a lot on your immunomodulator therapies, which are immunocompromising, and a lot of those are injection and not pills. So you may have to be you may have to be showing the caregiver how to give these kind of injections. They're not particularly fun. Some of them are sub-Q, some of them are IM, but you have a 6 or 7 year old kid, they don't understand why mom is giving them a shot once a week or once every 2 weeks. So you're just going to want to do lots of education. You're going to want to educate the patient. Some of the, and these are more clinical pearls than testing pearls, but almost all of the injections come in self injectors now, or auto injectors, where when you put it flush with the skin, you push a button and so it just goes in, so then the patient doesn't have to drop the medicine, they don't have to jab themselves. The problem with that is almost all these medicines are kept in the refrigerator, so you need to educate the caregiver that they need to leave it out for about 30 minutes to let it get to room temperature, or they can put it under their armpit to get to body temperature. The colder the medicine is when you inject it, the more it's going to hurt. Also, it's very common for patients to get some hives right around the injection site. That's not considered an adverse reaction, believe it or not. And so by you doing that, it does decrease the risk of that happening. Some patients do better with some ice to the area before the injection, and some patients do better with heat to the area, just to decrease those reactions when they get them. With the inflammatory bowel diseases, the Crohn's disease, and the ulcerative colitis, you are going to see some high-dose corticosteroids, which is going to further immunocompromise your patients. So don't forget that. So you want to talk to them about not being in large crowds of people, not being around sick people. One of the things that you need to remember about the high doses of corticosteroids, and these kids get a lot. They get like 40 milligrams a day. And when you've got a baby, that's a lot. Or even a 2 or 3 year old. They're often very thin because they've had so much GI issues with it. But one of the things to remember is anybody that's on chronic steroids almost always will have an elevated white cell count. So if you do a CBC and that white cell count is over 20, you're thinking, oh my gosh, they've got this massive infection. It may not be at all. It may be because of the steroids. If they do get an infection, a lot of times they will do Cipro or Flagyl for these kids. So be aware of that fact. Sometimes the inflammatory bowel diseases do require surgery and remove some of those pieces. Peptic ulcer disease, you can have a surgery on rare occasion, not very often, but on rare occasion you can. And on irritable bowel, you're not going to see surgeries at all. This is treated more therapeutically with diet and education, stress reduction, walking, those kinds of things. One of the other few little things I've got written down here to tell you is on ulcerative colitis. As you can see, it's at the end. It's on the descending colon, sigmoid colon, and anus. But the more of the colon that is affected, the worse the symptoms are. And that is true on Crohn's disease. While even though they can get it throughout, the more of their colon or intestines that are affected, the worse their diseases are. In ulcerative colitis, you're going to see, you can have blood in their stools a lot. And a lot of times I will ask my patients, did you see blood in their stool? If you did, was it just a little bit bright red blood streak? Well, that's probably hemorrhoid. But if you've got copious amounts or frequent amounts, and especially if it's mixed into the feces, a hemorrhoid, the blood will coat the feces, whereas ulcerative colitis, it's mixed in. So, kind of keep that in the back of your mind as well. They often will have frequent bouts with ulcerative or Crohn's disease of intermittent fevers, and you're not going to see that with the IBS. You're going to work them up, though, the same way. They're going to have those CBCs. You're going to have electrolytes. You're going to do the iron, the TIBC, the ferritin, the folate. You're going to do stool samples for blood, white blood cell counts, ova and parasites, cultures. You do want to check them for C. diff just to make sure. But there is an IBD, inflammatory bowel disease lab panel, and they are going to have a colonoscopy with a tissue biopsy. So just be aware of all of those things. I didn't talk too much about the peptic ulcer disease. Remember that the gastric ulcers are inside the stomach. Duodenal ulcers are on the upper portion of the small intestine. Most often, you're going to see kiddos with that either because they've had a long-term infection of H. pylori or long-term use of aspirin or other NSAIDs like your ibuprofen or naproxen. Contrary to popular belief, stress and spicy foods do not cause peptic ulcers, but they can make them worse. So, you do need to educate the caregiver and the patient on stress reduction techniques and the importance of doing that, avoiding those spicy foods as well. The people with peptic ulcer disease, you're going to see more nausea, vomiting, not wanting to eat, recurrent abdominal pain, change in eating habits. Just remember that you can see some life-threatening GI bleeds here. If they've got some dark tarry stools, that is a very concern. And once you ever smell a GI bleed, you remember that smell. It's a very distinctive, horrible smell. So, like I said, just make sure that you're testing for occult blood, white cell count, H. pylori. It's funny because in one of your textbooks it says the H. pylori blood test. Those have fallen out of the way. They found out that those H. pylori blood tests are only 40% accurate. So while they might do it on rare occasion, they're not going to do it that often. Most of the time, they're going to just do it in surgery when they take a piece of tissue. The other way you can test for H. pylori is a breath test, but the breath test, they have to be off of all PPIs for, it's a long time. It's like 6 or 8 weeks, and I don't know, I don't even have ulcers, and I don't want to be off my PPI for 2 days, let alone 6 weeks, because it makes me miserable. So I can't imagine it on someone like this. And you also don't want to make that GI bleed worse. So just make sure anybody that has bloody or black stools, especially if it's mixed in with the feces, they need to be checked. Any bloody vomiting or coffee grounds vomit need to be checked. Let's see if I told you everything I should have told you on IBS. Pretty much. IBS, a lot of times if there's some diarrhea, or some constipation in there, they do give you some Miralax to relieve constipation. One of the big things with kids especially, think of, you don't want them to get dependent on laxatives, and it can happen. So you want to make sure you're telling them that they're going to do a vegetable laxative or something like Miralax that is not going to be habit forming. And believe it or not, it can. You will see in their stools, in their colons, people that take chronic, especially adults that are on chronic laxatives, when you do the colonoscopy, their mucosa actually changes in their colon. It's really sad. How do you treat gastric ulcers? That is especially if, if it's H. pylori, it's a big, big deal. It is a triple therapy, and so you're always going to have 2 antibiotics and a PPI. Most typically, if there's no allergies, they're going to do amoxicillin and flagyl in the PPI. Now, if they're allergic to penicillin, you can do tetracycline if they're over the age of 8, but you cannot do tetracycline under the age of 8. Can anybody think of why? I wish you guys were here in class, because this is a big teaching fact, because you will see this most likely on your boards. Tetracycline is not given in little kids because it stains the teeth. So, and bad. So you want to make sure they're over 8. If they're allergic to amoxicillin, you can also give them clarithromycin. But they have to have all 3. In the recent couple of years, they have came out with one pill that has all 3 medicines in the pill. Super expensive. In fact, the VA finally got it. I think they said it was like $1,500 a pill. It was crazy. But it is out there. But if you've got somebody that is going to be self-paying, or, even if insurance is kind of cranky, don't do the one pill. It's not going to hurt them to take 3. So, because your PPI is only going to be once a day. Yes, your amoxicillin and flagyl is going to be more than that. Remember, with your flagyl, it does cause a lot of GI distress. So I would definitely recommend that they, do like a probiotic to help with that GI distress. And I'm hoping you guys can see this. I thought it was important to kind of look at these medications. I'm sorry, I'm kind of looking to the side here because I have to see it blowed up on my big screen, because on my small screen I can't see it. But, so you have your histamine antagonists, which is like your ranitidine. Remember, side note, that's why, because it is a histamine antagonist, that's why you also give Zantac during acute allergic reaction, and that's for a kid or an adult. But you're going to use that for peptic ulcer disease, GERD, hernia. You've got some Maalox there, and the Maalox interferes with the absorption of antibiotics and birth control pills. So make sure that you're not giving Maalox and antibiotics together, and make sure if it's a teenager that you are telling them, and don't just assume that they're not sexually active. They need to know that if they're doing birth control pills, that this can interfere with it. You see a lot of PPIs. We try not to use those as much as we used to. Even 10, 15 years ago, you had a little bit of acid indigestion. We gave you a PPI, and now we see, it's causing osteoporosis. It's doing all kinds of stuff. So we do still do it, definitely. And it does decrease the gastric secretion. Sometimes they do it prophylactically before surgery. But you do want to take this about 30 minutes before meals. You've got your Cytotec, which is an anti-ulcer prostaglandin that we give, and that decreases the gastric acid secretion, and it increases production of the mucosa and increases production of the mucose lining. But you do need to monitor for a GI bleed. You also want to monitor for a miscarriage. You do not want to give this if somebody is pregnant. I prefer not to ever give this drug, but you do see it used on occasion, so it's important to talk about that. One of my favorites is probably the Carafate, which is Carafate. It's an anti-ulcer. It creates or it coats mucosal lining. So how I like to think about it is, when you think of your stomach lining, you have ulcers underneath there. It's going to coat it and make a protective liner. So the goal is, while you're taking it, it keeps food or anything you're eating or drinking from irritating that ulcer, so that ulcer is down here able to heal up. So then you get back to that normal mucosa. They do need to take it on an empty stomach, and you are going to tell them to take it before every single meal and before bedtime. We use it in peptic ulcer disease, GERD, but not a lot in GERD unless the GERD is really severe. Lactulose, which is an osmotic laxative, it decreases the pH of the bowels and production of ammonia. It can give some jaundice. You got to monitor the bowels, diarrhea, monitor the potassium level. But we do use this for cirrhosis, just because it brings down their ammonium level, because it makes them secrete it. And it does make them urinate, and then constipation. Bulk forming laxatives, which is like your Metamucil, and what it does is it prevents constipation by softening the stool by removing the H2O. You're going to monitor the bowels, diarrhea, monitor for diarrhea and potassium. It's used for diverticular disease, and you'll see a lot of older adults use it prophylactically. Even not in diarrhea, not in diverticulosis, but just to keep themselves regular. Antidiarrheals such as lometeride or Imodium, it inhibits the peristalsis, which helps with abdominal cramping, but you do need to monitor the electrolytes, and there is an increased risk for gingivitis, so they need to have good oral care. Antidiarrheals and anticholerogenics, which is your Lamodal. So just remember, your Lamodal works completely different than the Imodium. and that slows down the GI system, but it does cause tachycardia, so you're going to monitor the electrolytes, and then it can also increase the risk for gingivitis, so proper oral care. And then last but not least, Reglan. Back 15 years ago, we used this on almost all patients that had H. pylori or some big GI thing. We do not like to use it now. It does increase motility for constipated patients, but we do not like to use it because of it can cause extrapyramidal systems, EPS. And when patients get that, it is permanent. So look up EPS, know what it is, and remember that on Reglan you can get this. You can also get neuroleptic malignant syndrome, which is life-threatening. So that's, it is a great medicine. Back 15 years ago, I used it all the time in patients and never had a problem with it. But because I know of these black box warnings, I will not use it for anyone now. I don't want to cause somebody to develop some kind of EPS, get some kind of tick or jerk and be permanent because of me, something I gave. So just be aware of that. GERD, I'm not going to spend a lot of time on GERD because we're already an hour into this. Just remember that a lot of babies have GERD. And you'll see that because they will vomit a lot. And it's not the spit up like you think a baby's doing. It is the projectile vomiting. And the reason why is they have the lower esophageal sphincter, the function of it is just not where it needs to be. Or a lot of times they call it the flapper on that junction where it's supposed to shut to prevent reflux just doesn't work well or isn't fully developed. So just be aware of that because that is what can cause the flow of that gastric contents back up into the esophagus. Remember that eating can cause them to have some abdominal pain. A large amount of fluid can be present with recurrent vomiting. Like I said, they could do projectile. They can have excessive irritability and crying, slower weight gain than normal. They can get a chronic cough, just like our adults. They can develop chronic episodes of pneumonia because of aspiration of the stomach bile. And they can have some sleep interruption because remember, if they're laying flat, it can go back up in there while they're sleeping. They can have persistent sore throat because of the bile coming up and burning their throat. So as a nurse, you're just going to want to make sure that you're, plotting out their weight, their length, their heads. You're going to check stools for cold blood, chest x-ray for respiratory symptoms. They can do a pH probe, and that's where they run the pH in and leave it for 24 or 48 hours. That measures the pH of their stomach contents at all times. They might do an esophagram, they might do gastric emptying studies, but in most cases it is EGD. Excuse me. Pyloric stenosis. So this occurs in babies when the pylorus blocks food from entering the small intestine. So normally the muscular valve of the pylorus holds the food in the stomach until it's ready for the next stage, but in stenosis that muscle thickens and becomes abnormally large, blocking food from reaching the small intestine. It can lead to forceful vomiting, dehydration, and weight loss. Babies are often seen as chronically hungry. It's found more in boys than girls, like 4 times the amount. And then higher incidence in families, especially the moms. You're going to see a forceful, progressive vomiting after each feeding. And they can have the onset of vomiting from the first week of life to as late as about 5 months of age. It is almost always projectile. And you can almost see in their belly the peristalsis from left to right before the vomiting occurs. It's actually pretty wicked. These kids often will have poor weight gain because they're not absorbing the nutrients because they're vomiting it out. So make sure, your babies that are diagnosed with failure to thrive, you want to make sure it's not child abuse, that there is actually a mechanical reason that these babies are not thriving or gaining weight. There is a small risk for jaundice. And a lot of times these kids will have an upper GI series, ultrasound, CBC, liver function. And you're going to use much of the same interventions as we've already discussed. NPO, they can suck on their binky, which really helps. A lot of times they are going to have surgical correction, not always, but a lot of times. If mom's breastfeeding, you may need to educate her on pumping and storing it. You're going to teach them how to care for the site and monitor for signs and symptoms of infection. You're going to teach them to look at INOs and make sure they're staying adequately hydrated. You're going to talk to them about making sure you're burping them. That's something I didn't say, but that's very important. And then remember that after the surgery, your patient may continue to vomit postoperatively because of the edema. So, educate mom and dad, caregivers, aunts and uncles, whoever's taking care of babies on the disease process and the healing process and what to expect. Volvulus. This is an abnormal twisting of the GI tract, usually the intestine, which does impair the blood flow. So remember, if that blood flow is cut off, that part of the intestine will die. It can be stomach, small intestine, cecum, or sigmoid colon. And malrotation of the bowel during fetal development can predispose them as a baby. And often they're going to have intense crying and pain that occurs acutely within the 6 months, pulling up of the legs, abdominal distension, vomiting that's usually bilious, tachycardia, tachypnea, breathing fast, and they're going to have an upper GI system, CBC. They're going to need surgery. So you're going to educate caregiver on, what to prepare for. The patient needs the counterclockwise rotation to restore the normal perfusion. And they may have to have bowel resection, so be aware of that. When they come out of surgery, they are going to have an NG tube. So again, you're going to want to make sure that their pain is adequately controlled. You're going to want to educate the caregiver on what to expect. Intussusception. This is when part of the intestine slides into the adjacent part of the intestine. And so it kind of telescopes and blocks food or fluid from passing through. It can, again, cut off blood supply. And it's the most common cause of intestinal obstruction in kids younger than 3. It can be caused by Meckel's diverticulum, polyps, or enlargement of lymph tissue. Kids often will have sudden drawing up of the legs and crying with possible vomiting, then can be symptom-free. But then pain will occur at regular intervals, usually about every 15 to 20 minutes. Vomiting does contain bile, and after 12 hours, they develop current jelly stools, and that's where the stool is mixed with blood and mucus. Increased abdominal distension, and as the problem gets worse, they get fever, peritoneal irritation, tachycardia, elevated white blood cell, and they need diagnostic testing of ultrasound, CBC, barium enemas, And you as a nurse are going to educate the caregiver, keep the patient NPO, make sure that they're getting adequate IV therapy. You're going to record their INOs. You can give the patient a pacifier to help with that suckling to calm them. Excuse me, guys. They are going to come out of surgery with an NG tube. And then when their bowel sounds return, then they're going to start them on a gradual oral feedings. Necrotizing enterocolitis is the death of tissue of the intestine, and it occurs most often in premature or chronically ill kids. And you see it after infection or ischemic incident, and you see a kiddo with tense, distended abdomen, large gastric residue greater than 2 milliliters, stool is positive for blood, increased periods of apnea, decreased blood pressure, poor temperature stability. And so you're going to see these kids having a blood work, a CBC, CRP, stool for cold blood, abdominal x-ray, increased abdominal girth measurements. And you're going to have the exact same nursing interventions as we've already talked about. One of the things to know, though, is that surgical intervention can cause short bowel syndrome on this. And it can also, bowel obstruction is a potential complication of short bowel syndrome. So just be aware of that. They may have some TPN. You're going to want to monitor these labs. You're going to want to educate and help parents get used to everything. And you're going to make sure that they're not getting liver failure. This could be really, really important, guys. GI problems manifested by diarrhea, gastroenteritis. No big deal, right? We see that all the time. But it can be a big deal. It's often defined as just the onset of diarrhea in the absence of chronic disease. They can have abdominal pain, but not always. Cramping, fever, nausea, vomiting. Honestly, gastroenteritis is one of the most major causes of morbidity and hospitalization in kiddos under age 5. And you see watery diarrhea, abdominal cramping, vomiting, headache. They can have fever. They can have stools with blood or pus. They can be dehydrated. And remember, on your babies, you're going to want to look for depressed fontanelles, lack of tears, poor skin sugar, lethargy. And symptoms can last 1 to 2 days, up to 10. So if you got a kiddo that's up to 10 days with these symptoms, they're definitely going to be dehydrated. Because if you remember, a kid has a larger skin to body surface area than an adult does, so they are able to get dehydrated much easier. We are going to do stool cultures to see exactly what kind of pathogen. Is it viral? Is it bacterial? We're going to want to treat for whatever it is. Most of these kids are given an isotonic solution such as normal saline, but then after they have some isotonic, you want to give them a hypertonic such as D5.5 normal saline. Just like kids are easier to get dehydrated, they're also easier to put in fluid overload. So you do want to definitely monitor as you're given the IV fluids. They are at a risk for metabolic acidosis and a risk for hypovolemic shock, especially, the more they're dehydrated. One of the good things that you can think of is, when they're acutely vomiting, tell parents not to give them anything for an hour. Let that belly calm down, because if they just keep on and keep on, it just keeps it stimulated. So have them stop for an hour. Then they're going to start with 1 tablespoon of fluid every 15 minutes for an hour. They keep that down, then they're going to move to 1 ounce of fluid every 15 minutes for an hour. You can also have them do every half hour. Pedialyte, water, popsicles, anything like that, clear broth, or saltines. However, when you are doing this, okay, sorry about that. I hope I can remember exactly where I was at. What I started to say is on the rehydration, when they're vomiting and you start giving, you start giving them the liquids, and for gastroenteritis, if when you started giving them that, if they vomit, you need to go back to square one. So if you're past the point of giving them a tablespoon of liquid, say you're up to giving them 3 or 4 ounces of liquid and they vomit, you need to go back to the tablespoon. So just remember that. Anyway, okay, new slide. Which of the following are signs of necrotizing enterocolitis? We just talked about this. Tense, distended abdomen. B is large gastric residual greater than 2 milliliters. C is stool positive for occult blood, or D is all of the above. These questions are not nearly as fun without you guys here, because I can't see what you would answer. But yes, the answer is D, all of the above. There it is. They can also have increased periods of apnea, decreased blood pressure, poor temperature stability. And remember, that just means their temperature is just very erratic, whether it's low, whether it's high, whether it's normal. And then they do have the stool positive for occult blood. GI problems with constipation. So first we have functional constipation. So I don't know if you guys remember from babies, but breastfed babies are going to have a diarrhea stool after each feeding. Babies that are bottle fed, that are not bottle fed with breast milk, are different. So we do end up seeing a lot of constipation in babies, as well as children, and is not typically caused by anything too major. They say the etiology is most of it is just functional or idiopathic, meaning there's no real cause of it. So typically the signs and symptoms, they're going to have infrequent stools less than twice a week. They're pretty hard. It can be small and pebble-like. They can have complaints of pain with stooling. They can have leaking of stool between bowel movements. And then you can see them because it kind of hurts. So especially toddlers, they may hold it because they don't want to go. So you may see them dancing around because they got to go to the bathroom and don't want to go. On physical examination, you need to make sure and palpate the colon or the and the abdomen. You need to do a rectal exam. Do they have the anal wink? Do you know what the anal wink is? That is where you look at the anus and look for fissures on rectal examination. Diagnostic wise, they're going to have an occult blood. They're going to have a KUB, which is an x-ray, or it's going to be a flat plate. Barium enema to rule out Hirschsprung's disease. They're going to have, they may have anorectal manometry. Did not say that right. But that's pretty infrequent. I'm going to be honest. I don't think I've seen more than 1 or 2 kids throughout my whole career have that. Basically, they usually determine there's no bacteria or nothing major causing it and don't put them through that. You as a nurse, your interventions, you're going to assess for impaction or the need for disimpaction, because remember, they may be admitted for disimpaction. They may need IV fluids. They may need enemas or oral electrolyte solutions. They may get some like Miralax for to help remove any kind of hardened stool. And typically they will try that before they admit them into the hospital for disinfection. Sometimes, so they typically do Miralax or Glycolax, but they can do mineral oil or lactulose. They can do some short-term therapy with Senecot. You may see some Ducalax and enemas. One of the best things you can do is educate on behavior modifications, increasing the fluids, increasing the fiber, which is hard on toddlers, especially because they want to eat and drink what they want to eat and drink. They don't want to take time to sit down and eat a meal. You need to educate caregiver to watch and monitor stools, increase the fluid intake, the exercise, elimination of cow's milk protein can help. They may need some biofeedback therapy. And then, you want to educate caregiver on when they should come to the ER. Hirschsprung's disease. This is a congenital condition that causes blockage of the intestine because of the lack of nerves in the bottom section. So you can see on this diagram right here, the bottom one, see how it's enlarged up there, and it just doesn't have it just does not have nerves in there. Those nerves normally allow the muscles in the wall to contract and move digestive material out. It goes down through the rectum and anus and out. So if you don't have those nerves there, you don't have that peristalsis to move that along. And it happens about 1 out of every 5,000 births. So, not that rare. Not as rare as you would think. It is more common in males. Some of the signs and symptoms is failure to pass the meconium in the first 24 hours of life. And remember, the meconiums is the first stool, and they can have some increased abdominal distension. These kiddos will often have constipation from birth, and they don't have bowel movements more than about once a week. They can have ribbon-like or watery stools. And typically you're going to see a thin child with a protruding abdomen. They don't get good weight gain. They vomit. And then diagnostic testing is going to be an empty rectum on the digital exam, because remember, that's going to stay up above that sigmoid. It's going to stay in that descending colon. They may do a rectal biopsy, a barium enema, a KUB. They may do the anal rectal manometry. I'm not saying that right, manometry. Your nursing interventions, again, is going to be IV therapy for fluids and electrolytes. They may need some antibiotics. They may need to be admitted and have surgery. You want to educate parents if they do need surgery. And you want to prepare the patient for surgery if they're old enough. And when I say that, if they're old enough, I mean the education portion, because you're going to prepare them for surgery regardless of the age. You're going to want to maintain the NG tube. Once they're out of surgery, you're going to, again, maintain that NG tube, monitor the operative site, administer the antibiotics, observe for complications such as enterocolitis, which is watery diarrhea, abdominal distension, and fever. You're going to treat with IV fluids. You're going to have warm saline irrigation and antibiotic therapy. And these are going to have GI follow-up, don't forget. So this is the Umphacil and gastroschius. With the Umphacil, the stomach and intestines are contained within a sac of amnio, peritoneum, and Wharton's jelly outside of the abdomen. Whereas a gastrius is an opening on the right side of the umbilical cord that affects the stomach, small and large intestines, and in rare cases it can have the liver in there. So you can see the big differences there. Clinical presentation, you're going to see a malrotation in both. Um, the oophocyl can be anywhere from 4 to 12 centimeters, so quite big, especially for a newborn. In large defects, you can see the liver, spleen, gonads, and bladder in the sac. The sac can rupture in utero. Most of these kids are by C-section, and they can most of the time see these during ultrasound before baby's born. They are commonly associated with other comorbidities such as cardiac defects, neural tube defects, Beckman-Whiteman syndrome, whereas the gastrius, the intestine is at risk for vascular compromise, which makes sense because, you know, it's very, since it's out there, it can be manipulated very easily. It's often matted with exudate. They normally have normal abdominal musculature, and it's pretty unusual to have any other anomalies like the oophocyl does. Diagnostic testing, they're going to have an AFP. And again, both of these are usually diagnosed on prenatal ultrasound, and they follow these kiddos all the way through pregnancy with the ultrasound. They do typically have an amniocentesis. And like I said, most of these babies are delivered by C-section. Some of them have to have resuscitation upon delivery. But so you as the nurse, you're going to help mom prepare through the amniocentesis, which is not a fun procedure. And it does typically, each one they do, if they do more than one, typically does get worse, even if, and they typically wait a few days before they do another one. But the more amnio fluid they pull out, the more the uterus is cranky or irritable, which causes more cramping. So just so you know that. You as a nurse on delivery, of course, is gonna be ready to resuscitate the baby. Respiratory support if needed. You're gonna wrap and support the defect to prevent fluid loss and hypothermia. You can use sterile normal saline with a non-adherent dressing. Newborns are going to need to be placed under a warmer to prevent heat loss, especially in those contents that's outside of the body, because they don't have the body to do that. They're going to have an NG tube, and they are going to have surgery to close them. They're going to have TPN, IV antibiotics. You're going to want to support their sucking needs by giving them a pacifier. You're going to observe surgical sites for infection, observe for defecation. You're going to want to educate parents on or caregivers on all of these things too. When the ileus resolves, they will start feeding them with breast milk or pre-digested formula. But some babies may have TPN for several months. They have very close follow-up, just so you know. Neonatal jaundice is caused by the breakdown of red blood cells, just like adult. Whenever you see some jaundice, when you have that breakdown of red blood cells, it releases the bilirubin out into the bloodstream. And you got to remember that a newborn's liver is sometimes immature and can't effectively metabolize the bilirubin and prepare it for excretion. You can see yellow on the skin and whites of the newborn's eyes up in the sclera. And you know, you do have to remember in newborns, a lot of newborns do have a very low case of jaundice, and it's no big deal. But and so the normal neonatal jaundice typically occurs between the 2nd and 5th day of life and clears with time. But a high level bilirubin and hyperbilirubin is not, and it can cause the infant to be sleepy, eat poor, and this can cause the jaundice to get even worse. They can usually treat them with bilirubin lights. You want to make sure they're getting adequate INO since they have poor feeding. You want to monitor for signs of infection. You want to monitor for bilirubin encephalopathy, which can happen with severe jaundice. You want to check for a hypotonia or hypertonia. They may have some high-pitched cry. They can have seizures. They can have poor suckling. So again, you want to stimulate it with the pacifier. Diagnostically, they're going to have a millimeter assessment or screening test. They're going to have some blood work, a bilirubin, total and direct, a CBC, a retic count, UA, urine culture, blood type, Combs test, CRP, blood culture, and so lots of different things. And if they do have an elevated direct bilirubin level, they're going to have a liver function test, gamma glutamine transference test, alpha-1 antitrypsin test, TSH, remember that's your thyroid, and cortisol. They're going to ultrasound the gallbladder with any elevated direct bilirubin. You, as the nurse, are going to remember that any bilirubin greater than 20 milligrams a deciliter are going to need admission to NICU, not just the hospital, NICU, for phototherapy. Bilirubin greater than 25 milligrams per deciliter may require exchange transfusions. You as a nurse are going to have some transcutaneous billimeter readings. You're going to encourage the mom to feed them frequently, provide lactation support. They're going to have lots of follow-up after hospital discharge, and you want to make sure that the caregiver understands. They may need additional fluids or phototherapy at home. And then they may have an exchange transfusion if that level of bilirubin remains high. If the jaundice develops after the first week and the bilirubin stays high, they may interrupt breastfeeding for 12 to 24 hours to reduce the level. This is not done a lot, but it is done on occasion. One of the big things is we used to thought indirect sunlight helped, but it does not. Research has showed, and you'll learn in healthcare, things are always changing as we get additional research, and this is one example. Biliary atresia is a congenital absence or closure of the major bile ducts that drain bile from the liver. So it results in a progressive inflammatory process that does cause cirrhosis. These babies get significant jaundice about 2 weeks of age. There's an increase in the direct bilirubin, and it's usually greater than 20% of the total value. There's poor absorption of fat and fat-soluble vitamins. And remember, your fat-soluble vitamins are your DAKE. These are the ones you become toxic at, and DAKE is D, A, K, and E. These kiddos are going to have a dark urine. They'll have light-colored stools, and after 2 months, they may be pale gray or white. They can have an enlarged liver, and diagnostically, they're going to have liver function tests. And remember that the AST can be normal early, but then it does get elevated. They're going to have total and direct bilirubins. They're going to have an elevated alkaline phosphatase. They're going to have an ultrasound of the abdomen and liver. They're going to have a liver scan and biopsy. Just a second, guys. I apologize. Sorry, guys. Just a couple of more things I wanted to talk to you about on that previous slide, and unfortunately when I hit the pause button I can't go back to that slide, so I'm really sorry about that. But non-alcoholic fatty liver disease, that's important to know. And there's two different types of it. There's simple fatty liver and non-alcoholic steatohepatitis, which is your NASH, and they are two completely separate conditions. And some people can have both, so just be aware of that. They typically have one and then develop the second one. Simple fatty liver is where the patient has fat in the liver, but little or no inflammation or liver cell damage. The simple fatty liver typically does not progress to cause liver damage or complications, whereas the NASH is where the fat in the liver is present along with inflammation and cell damage. This can cause fibrosis and scarring, and it can lead, remember, your NASH can lead to cirrhosis or liver cancer versus simple fatty liver. We're seeing both of these a lot more common because of the obesity in our kids and adolescents. It's typically asymptomatic, but some kids may have fatigue, right upper quadrant pain. They may have some insulin resistance. And remember, they can have that encathose, that hyperpigmentation. You see it like, especially like around the chin, in the waist area, in the armpits, from people that are getting that insulin resistance. We want to educate them to have minimal or no alcohol consumption. They can have diabetes. PCOS is very, very common in this. And remember, PCOS is polycystic ovary syndrome. And so these people are going to have hormone issues. So menstrual cycle irregularities, heavy menses, painful menses, weight gain. So just be aware of that. All right, cystic fibrosis. This is this is hereditary. Let me turn off my heater. I'm getting really hot. Cystic fibrosis is hereditary. It causes the production of a lot of thick mucus. It can block the pancreatic ducts, intestines, and bronchi, resulting in respiratory failure. Your assessment is going to include checking for pulmonary problems. You're going to check the effect of the pancreatic exocrine gland function. Is the baby or kid failure to thrive? Are they meeting normal developmental milestones? Are they having chronic diarrhea, respiratory symptoms? Their first manifestation can be meconium ileus. Remember that meconium is the first stooling after birth. They can have a lack of passage of meconium for 48 hours. They can be diagnosed by a barominema. They can have a rectal prolapse, pancreatitis, diabetes. Slow growth in nutrition, like I said, so you really want to watch those physical and cognitive milestones. They're going to have that sweat chloride test. And you guys actually had a test question last time on the sweat chloride test. And it's going to be positive with elevated chloride. Once you have that diagnosis, you do not need to keep doing that. I think that was the test question. You do want a chromosome analysis. A 72-hour fecal fat test. You're going to teach, or you yourself are going to assess for signs of intestinal obstruction with meconium ileus, recognize and treat signs of pancreatitis. You're going to want to educate the caregivers on the disease process, things to watch for. You want to support nutrition, support breastfeeding if mom wants to breastfeed. Baby's probably going to be on pancreatic enzymes and fat-soluble vitamins. Remember, that's a DAKE, D-A-K-E. They may take cystic fibrosis transmembrane conductant regulator. You're going to really watch these kiddos for their growth and development. You're going to have to teach parents especially that they cannot skip those pancreatic enzymes, because this is what's helping them break down the food. And enzymes for infants and young kids should be mixed with a soft acidic food like applesauce and not with milk-based foods such as yogurt. So that's really important to educate the parents as well. Enzymes should not be mixed in food ahead of time and should not be refrigerated. If a child is on a tube feeding, you're gonna you're going to take it in the mouth before the tube feeding. You're going to really work on proper nutrition. And then remember that that kid may have to have a G-tube. So that's important. Cholecystitis, sudden inflammation of the gallbladder. Again, as we're having kids with more and more obesity, we're seeing this. If the condition persists for months, it becomes chronic cholecystitis. Gallstones are small, hard, crystalline masses formed abnormally in the gallbladder and bile ducts. These can cause a lot of pain and blockage. Gallstones and cholecystitis itself both can cause jaundice, fever, right upper quadrant pain, vomiting. Sometimes that pain can go up in that right shoulder as well. It can refer up there or radiate up there. They are gonna be tender to palpate in that area. They're gonna they should have a CBC, a bilirubin test, alkaline phosphatase, amylase, UA, liver function test, a KUB, and an ultrasound. And just a couple of things to remember on educating. They don't take out gallstones in infancy unless they're causing issues. Gallstones do typically resolve spontaneously. So that's really important. Laser lithotripsy, if you think about that, if you think laser lithotripsy is what they use for bladder stones in adults, but they're currently experimenting that on gallstones. So just FYI. But if they do have surgery, you as a nurse, you're going to educate the caregiver on how to take care of the sites, monitor for signs and symptoms of infection, monitor for jaundice, making sure their pain is under control. Your typical gallbladder. Surgery does usually correct the problem, but the goal is for them not to have surgery. Hepatitis is a disease that is inflammation of the liver, usually resulting from a viral infection or liver damage. You're going to remember different types of hepatitis. Hep A is oral fecal contamination through food or environment. Most typically, you see that from like salad bars, where a worker or maybe even a patron has went to the bathroom, not washed their hands good, had fecal matter on their hands, even though they couldn't see it. It's microscopic. They pick up the salad tongs, and guess what? You're right behind them picking up those salad tongs or whatever utensil it is, and you get it like that. That is the majority of way people gets it. Hepatitis B and C are both caused by exposure to infected blood or blood products through sexual contact. Hepatitis B can be spread from mother to infant during delivery. A, B, and C hepatitis can be asymptomatic. And I know you guys just talked about this with Dr. J and the adults. So much of it is very similar to peds. They can have, if they're not asymptomatic, they can have jaundice, abdominal pain in the right upper quadrant, fatigue, malaise, loss of appetite, low-grade fever, dark urine, light-colored stools, enlarged spleen, petechiae, ecchymosis, spider angiomas, and diagnostically, you're going to do liver function tests, including alanine aminotransferase, and then you're going to want to do the sero test to see if you suspect hepatitis, which hepatitis is it, because that depends on how it's treated. Hep A, you're going to have an anti-HAV IgM and an HAV total. That way you can see if it's a recent acute infection or previous. Hepatitis B, you're going to do a surface antigen and a surface antibody, and then hepatitis B with an E antigen. Hepatitis B core antigen. I can never remember all of these, so I keep me cheat sheets. You guys will find that you will keep cheat sheets on things that you maybe don't do all the time that is nice to be able to look at. Hepatitis C, you're going to do an anti-HCV test for the antibody. It indicates infection past or present, but does not differentiate. So then if you have a positive that, you're going to confirm with the HCV REBA and HCV RNA assay, which is a viral load. The viral load is the most sensitive and what we use for treatment of Hep C patients. Viral genotyping may also be used. They can do ultrasound, liver biopsy. You as the nurse, you're going to, monitor for signs and symptoms of acute liver failure or chronic liver failure. You're going to want to monitor for development of ascites. And remember, that's that fluid wave in the stomach because the stomach is getting fluid accumulation. You want to do good hand hygiene and standard precautions, prevention of needle sticks, balanced diet that prevents dehydration, bed rest. And then for hepatitis C, we do antiviral therapy. There's a lot of combo drugs used for this. Hep A, we don't do a lot of things because usually they typically clear that themselves. But we do tell you to keep them out of school and daycare until the virus has cleared. We do recommend, though, that the family members of anyone with hepatitis A or B get immunized. And then children who are not infected should complete immunizations for the Hep B at birth, 2, 4, and 6 months. All moms should be tested for Hep B during pregnancy. And if they're high risk for Hep B, even if they're negative for beginning pregnancy, you do want to test them again before birth. But that's only for your high risk moms. GI problems manifested by nutritional changes, obviously obesity. And obesity is where the BMI is greater than 95% to be considered obese. BMI of 85 to 94% is considered overweight. And we start seeing adipose tissue at a young age. A lot of these kids will have knee pain from carrying around the extra weight, abdominal pain, daytime somnolence, PCOS, menstrual irregularities, acne, hirsutism, infertility, diabetes, fatty liver, heart disease, hypertension, hyperlipidemia, obstructive sleep, gallbladder. So lots and lots of different things. That's why it's super important for us to be very proactive in recommending, being physically active, healthy diet, checking the height, weight, BMI at each visit. The kiddos that are at risk for obesity or have obesity, they need to have CBCs, lipids, CMP to check that fasting glucose, TSH, a morning cortisol level. You can do a skin fold thickness test. And remember, that's where the caliber measures sub-Q fat from several areas. Sometimes they need an ultrasound of their gallbladder or liver. You may need to do a sleep study to check for sleep apnea. And then your nursing interventions are going to be the same as an adult with obesity. One of the things, though, that sometimes you can talk about these kiddos more so is how fast they eat. And sometimes they will, especially like 5, 6, and 7-year-olds will be more, what do I want to say? They're more likely to comply and listen to you than a teenager or adult. And they are starting to do more and more bariatric surgery in teenagers. Bariatric surgery is a great tool, but it is a tool, and I think often people are led to believe that it is a cure-all, and it's not. Any bariatric surgery, no matter what it is, within 2 years, the body is such a miraculous thing, is going to go back to the way it was. So if in that 2 years, if that patient has not learned new dietary habits, new ways to cope, because eating is often a coping mechanism, then they are going to regain that weight. You want to also advise these kids not to smoke, because sometimes adolescents may use smoking as a weight control strategy. Failure to thrive is defined as weight is less than the 5th percentile on multiple occasions. So it's more than one. They often have vomiting, food refusal, food fixation, abnormal feeding practices, anticipatory gagging, irritability. Their developmental skills and milestones may be affected. They may have chronic physical problems. There may be psychosocial problems in the parents. Often they're going to have diagnostic testing such as height, weight, BMI, physical exams. They're going to have developmental milestones checked, family, psychosocial, looking at the history, vital signs, feeding assessment, looking at the quality of food, ability to suck, chew, swallow. Again, checking for some of those things that we talked about. Maybe they have a mild cleft palate that no one's ever noticed. So they just want to check all of that. They do sweat chloride tests, stool samples, TSH, chest x-ray, renal ultrasound. Again, looking for every single cause that it could be. All right, which is the following is a correct statement? Anti-HIV IgM confirms diagnosis of chronic hepatitis A. Hepatitis B antigen, if positive, is the earliest indicator of active infection of hepatitis B. Anti-HBC total is the last antibody to appear after the appearance of hepatitis B, A, G, or D, none of these. The correct answer is B. Hepatitis B antigen, if positive, is the earliest indicator of active infection of hepatitis B, is also present in chronic disease or carrier state and does not become positive after immunization. That was a lot, guys. I thought I would have it done in an hour, and here we're on an hour and 47 minutes. I apologize, but lots and lots of information. They don't vary a lot, though, between adults and kids. So if you know this stuff in adults, it's going to make it a little bit easier. I will work on getting your Chapter 16.
I'm not sure I understand.
Sorry, Siri. I will work on getting your Chapter 16 recorded next and get it sent out. Thank you. You all have a great day.